needed to basically do that and come to grips in terms of the business that it stood as, to begin to make investments in it, to grow it. We had very, very attractive financials from a company standpoint. By 2010, we were close to about $30 million in recurring revenue. We had about $7 million and $8 million in the bank and $7 million in EBITDA. And we were profitable since 2007. The books and all you have seen, but a couple of things I do need to mention to you. We began to evolve as a team in terms of bringing everything together. So, for example, our sales and marketing teams ended up creating, because we had a distributed sales force across 12 different states, ended up creating portals that literally they could access with all of the information that they needed to in order to function out there in the field, with open source tools like Drupal. We also were not afraid for our clients to actually talk to us. So we actually created a Facebook type-like environment called Clinical Cafe that our community of users, we had over 1 million users that were actively using us. So we created an environment where they could actually just communicate, and even if they say bad things about us, we need to know about it, right? That's only how we can actually improve. What was the opportunity that others saw in Quantros? Well, we had a huge penetration in the client base. We were in the hospital market where others were actually struggling. We had a huge upsell opportunity, over $200 million of opportunity, and a remaining client customer segment that was still untapped, that others could perhaps tap into. The opportunity, if we were to look at the US hospital market in its totality, was close to $2 billion for Quantros, if it were to continue to attack that in a very aggressive fashion, not forgetting international. So everything, by the way, that I'm saying that is occurring in the US, or that Quantros was addressing, or is addressing in the US, is actually occurring internationally. In India, believe it or not, for those of you, the physicians that are here that have actually traveled to India, guess what? The Indian hospitals have a stamp just like the hospitals over here. They have the Joint Commission over here. In India, they have Joint Commission International. Those guys are basically accrediting hospitals like Apollo's and Max and Fortis and the others, because they're actually signing contracts. About a year ago, Fortis signed a contract with the DoD to actually take care of their veterans in India. Right? So a lot of all of that is actually happening. We had strong financials, as I actually indicated, gone over that quite a bit. And we had also created very strong competitor barriers to entry, meaning that as a company, we had assets that literally were unique to us, both in terms of a technology platform that we had, a comprehensive solution suite, meaning that there was no one company that actually had all of the kind of things that we did, but all together for a particular hospital, right? There were companies that provided only maybe perhaps a safety and risk management solution, but not the quality solution or the compliance solution. We were much more comprehensive. We had the data access, all the data centralized for reporting purposes. We had a very good integration schema across all of our technology solutions. And we also, as I indicated, no competitor had the breadth or depth of comparative data assets that we actually had managed to amass. In the world, we have the largest database on medical errors. Outside of the Joint Commission and Center for Medicare and Medicaid Services, we have the largest data on quality reporting. So in seeing all of this and seeing the success of the company in the fourth quarter of 2009, the board actually requested the management team to look for an exit and seek that particular exit as an option. As the management team, we actually focused on finding the right partner for the go-forward journey for Quantros. It had to be the right fit in terms of the product strategy in order to exploit the market opportunity and provide for optimum shareholder value, as well as provide the right structure environment for employees and management staff that were to continue with the company. We enlisted the help of Ziegler, our investment banking firm. They're a boutique firm that actually specializes just in healthcare IT companies. And we identified 3 strategics and 3 private equity firms that actually came to the table. This was not an open auction, this was basically by invitation only because we were not necessarily up in the market for sale. Actually, Oracle had done a due diligence with us about a couple of years before that, if I'm not wrong. In Q3 of 2010, we narrowed the choice to 1 strategic and 1 PE firm. And in October 28th, we signed a deal with Francisco Partners. It had a healthy portfolio of 5 other healthcare IT firms in their portfolio. So, what were some of the lessons learned? So, pretty long journey. I mean, I've curtailed it very, very briefly. A lot of lessons during that particular period. The solution that you create is only a fraction of the overall journey. It's never the solution. It's literally the team that makes that particular journey happen. Okay, you can sell anything, you can create anything, but it's the team that will actually enable and make that thing very, very real. It's best. So one of the faults that I had was, I was involved in a lot of things, and really trying to drive a number of things. Perhaps it would be better if I didn't drive everything, but just functioned as a catalyst for a number of those things. So serving as a catalyst and not the driver all the time, empower and enable others to take charge, to drive the journey. I mean, Vish taught me some of all of that, as we progressed. But you gotta remember, it's so difficult to let go sometimes when you're that driven, right? Listen to your customers. Never forget that your revenue is because they are using your products and services, right? Always be attentive to that. Never forget that. It's extremely important to understand. And synergistically leverage and partner with other vendors to gain market strength. You don't have to organize a sales force of your own. If you have to give 10 cents extra on the dollar to somebody else, let them deal with the headache. I can tell you what it is like to deal with salespeople, or find really, really good salespeople that work. Why do you want to go through that? If somebody has figured out that magic formula, let them have it. They will at least. The longer your product doesn't sell, it's sitting on the shelf. It's not making you any money. So any extra contract actually helps. Establish an attitude for what you stand for. I think that's something that companies forget. Do you want to be adversarial? Do you want to be contrarian? Do you want to be, how do you want to be viewed as in the industry? Because we were actually entering the industry in a field that was very not yet ready, we became more educational in our orientation and literally established the stamp of, if you wanted to address patient safety and quality, you got to be thinking of Quantros. You got to be thinking of Dr. Kumar, because he might have the right answers for you, for your organization. Why not call them to basically come in and help you out? So we established that kind of an attitude. And a story only begins after a journey is started. So a message to all of you, a number of you, are entrepreneurs in this room, right? Or claim to be entrepreneurs. Start that journey. It's only after you start that journey, will your story actually begin. If you do start it, now let me give you some pointers over here. And these are very, very fresh pointers, okay? Why is it so important for you to be thinking of healthcare IT, and why I am so energized about healthcare IT? I think for anybody not focusing on healthcare IT as of this particular point in time is not thinking right. Because literally, there are over $20 billion that have recently been pumped into the healthcare IT industry. To do what? To digitize and connect healthcare. What is that going to result in? Massive amounts of investments in infrastructure, bandwidth, and connectivity of data. What will it require? More interfaces of data, more needs for data storage, more needs for basically providing intelligence out of data, more to do with basically how you can view patients across the continuum of care, right? More technologies that will actually enable efficient care to be provided at home. So I think Kishore sitting over there, he's pioneering technologies at his new entrepreneurial startup called Abadyne to actually provide for remote patient care, right? these are technologies that will become I think the technologies that will leapfrog healthcare into the next generation. Let me give you a statistics that you need to know. Um, every 10 seconds, how does that go? Every 10 seconds, about 7 diabetics actually pass away. Okay? That is over 4.3 million diabetics in a given year. Do you know how much diabetics cost the healthcare system? $465 billion. Right? What is the GDP on healthcare for this country? $2.2 trillion. That's almost, what, 20-30% of that? Huge chunk. How can diabetics be taken care of better? You think diabetics are taken care of in the hospital? No. It's actually in their homes, right? You gotta basically take better care of their glucose so that they have less complications and they suffer less so that they do not actually end up requiring some of the end-stage therapeutic treatments that they actually require that are so expensive, right? So that's how we have to think. I think we have to think very radically in terms of what technologies are being enabled. Technology infrastructures are coming up very, very rapidly. Right? I see Kamil over there with a company that he actually invested in a number of years ago called Xstore, that literally provides for better storage management solutions, right? For images, medical images. All of these things are beginning to now come to forte, meaning that as technologies evolve, a number of all of these things are going to come about. Don't think that entrepreneurship in healthcare is all about going and seeking FDA approval for a new drug or a new device or a new iPhone app. No, it's not. It's about thinking very practically what the needs are today. If one of you can actually literally come up with a better means for interfacing healthcare data in a very seamless fashion, I can assure you Prashant would be very happy to listen to you from Oracle, right? Those are the kind of solutions that are literally needed as of this point in time. Okay? Thank you very much for your time, and I'll take any questions that you might have.
Sanjay, for an insightful and amazing story. So we'll have some questions. So let me start with a couple of questions, and we'll open to the audience.
Sure.
So, one question I had was, like you practiced, you were a practicing doctor for 6 to 7 years, 8 years.
8 years.
8 years. So did you have any family pressure on, getting out of that and trying to get into health informatics?
I mean, for a number of years I was actually practicing. For a number of years I was actually practicing as well as trying to start up the company. For the longest period of time, I don't think my parents really knew what I was up to. I know that every parent's dream is to have their son practice medicine, but I think my parents gave up a long time ago.
That's good. So another question was on the funding. Looks like, so you never have to take any money after the first 2 million plus convertible? That's amazing.
Well, I call us lean, mean, and thin. And thankfully to Vish's mentoring and guidance and our perseverance as a company, I mean, I would say we came very close in the earlier years. 2003, 2002 were the bad years, and then 2005, 2006, we had taken on a lot of projects that were costing us a lot of burden and a lot of expense. In that year, we actually had to shelve off a number of things, so revenue actually dropped quite a bit. But we just hunkered down. We were not that many people. We didn't have, as I say, that much superfluous baggage, or fat, as people might call it, so we survived. But the danger in all of that is that you didn't have that much, residual bandwidth. You didn't have people that could literally, if somebody was out sick, to do something else, so the pressure came on the team quite a bit.
So one last question before I open it to the audience. One of the points you made in your takeaways was that establish an attitude for your company, what it stands for, like adversarial, contrarian, but you didn't say what was the word which you used for your company to stand for?
Informational. We actually informed the industry regarding what quality and healthcare or patient safety, how it needed to be addressed. So there's something that really gave us a lot of pride and joy, and I have to narrate this story. In 2003, 2004, we actually came up with a patient safety event taxonomy. We actually researched all of the different event reporting programs that were there in Australia, in Great Britain, and in the US, in multiple states, and we developed a very elaborate, exhaustive patient safety event taxonomy. That taxonomy we actually implemented in a very practical way in our solution so people could actually collect standardized data. Believe it or not, in 2005, the WHO published a draft patient safety event reporting taxonomy. And mind you, we actually also sat on the Committee for Patient Safety Interest Group with the HL7 committee. So we were actually informing them quite a bit in terms of our work, not necessarily sharing everything, but they came out with a patient safety event taxonomy and configuration that was very close to what we had already pioneered. In 2007, WHO actually published that taxonomy and made it worldwide. So.
Okay, so we'll open it to the audience. Any questions?
What do you do now? Are you still involved with the company that has acquired? Your company is acquired now?
Yes, the company got acquired in October of last year, and I actually exited the company in April of this year.
So what are you doing now?
Taking a little bit of break and mentoring some companies and working. I'm actually working part-time with Xstore, helping them to actually develop a stronger go-to-market strategy for some of the solutions that they have in the marketplace, and mentoring a number of other companies to actually get off the ground. That's what I'm doing.
Other questions?
Can you talk a little bit about the sales cycle in the earlier stages, right? I think the time to close a deal versus getting requirements that were perhaps conflicting based on the sales you're making. I think that's pretty challenging for early stage startups. I work with an early stage startup and want to do that kind of
So you're bringing up a very, very important and very good question. In healthcare, it's not easy to sell. Although once you sell, they're the greatest customers to have, because so long as you service them appropriately, they will love you to death and they will never let you go. Sales cycle for us, depending upon the product, was anywhere between 3 months to about 12 months. In some cases, more the latter, 9 months to perhaps even, there was one account, I can tell you, a large IDN in the Bon Secours medical system, healthcare system in Baltimore, took 2.5 years, right? They never gave up on us. They told us they will come back if it didn't go into the budgeting year. You know, so long as you stick by them, you will get in there. Now, the stronger your ROI message, one of the last bullets that I had, if you can actually provide them with all of that, they work as a committee. In healthcare, it's all about not necessarily a unilateral decision that somebody basically makes. It's decision by committee. And that committee, the more food that you can give to them to go back and strengthen their case, then you're better off. I can tell you that there are certain departments that literally don't get funded. Now, one of the things that actually began to help Quantros in the later stages was that we were no longer a CapEx expenditure, we were an OpEx expenditure because we were a software service ASP model. Okay, so a number of all of those things actually begin to help the business as we evolve and curtail the sales cycle. For us, our regulatory reporting management solution, actually the sales cycle on that is 3 to 6 months. The safety and risk management application took far longer, 9 to 12 months to actually close, but it was a much higher sales value.
Next question. Can you get the mic?
Dr. Scott.
So I come from a medical background and I've been tinkering with these ideas for 10 years. But the language you're speaking is entirely different from what I can speak. And I'm totally consumed by patient care all the time. So what do? Go back to Nigeria to learn some of these things?
No, that would be the wrong place as an American to go. I mean, I don't know where your question was headed, but literally, I mean, the language is not necessarily new for people that are actually in our area of our domain, right? I mean, this is what I did for a living, I mean, mind you. You actually aid in some of all of that in your institutions, believe it or not. When you, I'm sure when you sit in your medical staff, most likely, although we're not allowed to look you up like that. But what I'm saying is that when you sit in your medical staff committees, if you notice all of those indicators like time to thrombolytics, or whether aspirins were given within 24 hours of arrival, our systems are aiding collection of all of that data. And they get reported, and most likely some of your paycheck gets influenced by some of all of that these days, because they're all part of pay for performance.
Where do you see in the next decade investments going into healthcare, and what kind of innovation do you think is expected to happen in this industry?
Again, I think a very thought-provoking and a question that literally lends itself for us to think rather broadly and see where healthcare overall is actually headed. Overall, healthcare is, if you look at it from a very global perspective, if anybody thinks that healthcare will continue to get funded and paid for in the way that it's currently being paid for, it's impossible. It's not. Healthcare, even in this country, is eventually going to be headed towards a single-payer type system. Okay? Or it's going to actually end up being a system that requires people to pay for what they're going to be utilizing from the system. Okay? So people paying for their own services. Evolving those kind of platforms to actually allow for that, providing more comprehensive, cost-efficient care for the patient on demand from their home, that they can actually utilize or service them in a much more cost-efficient fashion, are going to be the direction that things are actually going to move. Data, irrespective, is going to begin to get organized. It's already beginning to get organized. It's come a little bit too late to healthcare, but there are companies like Oracle and others that are making huge investments in terms of really establishing more robust platforms to collect all of the data that is needed to be able to inform healthcare providers what they need to be doing, right? Now we need to enable solutions on top of all of that. That's where the next decade is actually going to go to. Meaning, how do you now tap into all of these healthcare information exchanges that are literally being established either for guiding research, guiding new therapies, or just collaboration amongst physicians in order to provide for the right kind of care that is actually needed for their patient populations. I mean, if physicians could, for example, I would challenge the physicians over here, you probably have a panel of how many patients? How many? 5,000. Out of those 5,000, can you tell me how many of those have are you a cardiologist? How many have congestive heart failure?
My patients actually, at least 50-60% would have congestive.
50 to 60%. Now there's big.
But that subspecialty dictates that.
Right. But that's a big variation. How many of those do you think are actually under good therapeutic management and control?
There's a lot, like you said, it's the extension of the care beyond the hospital
Right.
care is the way to go.
Right.
And that's what I think I was in one of these national NIH, Institute of Hospital IHI, Institute of Hospital Improvement.
Yeah.
So there they were talking about all medical homes,
Yes.
that communication with the extended care,
Mhm.
the home care. But the problem with that is again funding. See, in America, anything that is a charity style doesn't go anywhere. Anything that's business model is likely to go. So ACOs, for example, accountable care organizations, it's announced by the government,
But
nothing's happening. Nobody's biting at it because it just mostly looks like a charity model. So, like you said, but this country will be forced to change their attitude towards that. So it's a very slow process. It'll happen.
Yeah. But if you had the capability of, let's say for example, getting into your office and literally pressing a button that basically could inform all of your congestive heart failure patients
Yeah.
on perhaps some new treatment modality or how best to take care of their diet or watching out for certain signs and symptoms, and that could be streamed to them on a private channel owned by you, would that not be great?
It'll be very good. And it's a,
So that's where healthcare is headed. Healthcare is actually headed to be able to do more than to be able to do for one patient, but to do it actually for thousands of patients in a much more cost-effective fashion. So I think the next decade will define that.
There was some reference to terminology. One of the challenges that at least I see, and maybe you can comment on that, is that it is easier to control terminology within an organization. But when you look at healthcare exchanges, the variations in terminology are so significant, it's very difficult to match one against the other. Do you see something happening in that area? Because coding itself is not doesn't seem to be doing it.
Yes and no. I mean, so the answer to that is yes and no. I think finally with healthcare information exchanges, one of the things that will be mandated or that will actually become more paramount for healthcare to adopt will be HL7 standards. If healthcare does not establish certain standards like the way that other industries have established and abide by, they will not go anywhere in terms of really exchange of good data or good information. Most of the folks that I know of today are actually beginning to comply with HL7 standards as well as the CDA, the clinical documentation architecture, the CCR, the clinical continuous care record, methods. So those, in my opinion, are actually going to become that much more adopted or established. You're not going to be able to shy away from that. Now, in terms of coding standards, those are still yet to be established in terms of what will take center stage, whether it's going to be SNOMED or whether it's going to be the new ICD-9 still, or it's going to be a collection of the two with a marriage, for payment purposes different, or for clinical care documentation, you're going to be using, SNOMED and the others. But that will evolve. I mean, nobody's got all the answers yet, but I think very rapidly for health information exchanges to succeed, those have to occur.
I think from a billing perspective, the standardization is probably getting there in terms of the coding. It is more from the clinical information where the challenges are because there are different ways of describing the same condition between doctors. So is there something that will happen there? SNOMED is a standard where it's not followed very closely.
But it's becoming more prevalent. What I would actually say is that today there is no predominant standard, but SNOMED is well recognized and well established. I mean, in pharmacy you have got MEDRA, right? I mean, so in each area there are different ones, and mind you, some of those did not get promulgated before because they were restricted by the licensing that was there. Now that even for CPT today, CPTs, there's no more, the licenses are much more freely distributed. So some of those restrictions being removed in terms of their utility will allow for better adoption. Before, the adoption was not there because they were actually price prohibitive in terms of the way that you could use them.
The changes Obama is trying to bring about in healthcare, being like.
In this term or next term? Or
I don't know, maybe next term, right? There'll be a lot more people in the care than, than the system can. The system is already struggling, right? How do you see those changes could help, or what kind of new innovations that would help them to offer the service for larger people,
So number one, so that's multiple different things in your question that let's dissect a little bit. Healthcare expenditure, irrespective, is going to continue to increase, okay? As populations actually age more and live longer, healthcare expenses are going to be much higher. 20% of your healthcare dollars are actually, 80% of your healthcare dollars are spent by 20% of the population in their last 5 to 10 years of their life, okay? Every day there are about 10,000 baby boomers that are actually coming of age, right? And they are beginning to age that much more and live that much more longer. So irrespective, your healthcare dollar that the government can actually provide or the care through the systems that are there will only go that far. They will not necessarily be sustainable for the long haul, not in the next 2 decades. What can be provided for is much more distributed, let's put it this way, if there was an Expedia for healthcare, would you go for that? If there was enough data, just like the way that you have data on hotels, to be able to select, let's say you needed a knee surgery. Would you be willing to pay $50,000 in the US over here? Or maybe $35,000 in Louisiana? Or $25,000 in Oklahoma? Or $10,000 in Chennai to get your surgery done? Right? In the later equations, you don't even have to pay your copay. Right? I think as accrediting agencies begin to consolidate their standards and begin to certify hospitals, that the Apollo Hospital in Chennai is equally as good as a Johns Hopkins in Cleveland, or in Baltimore, or a Mayo Clinic in Cleveland, you're going to end up having much more cost platforms that will actually allow for that. Now there's a company that I can tell you that's called Bridgepoint Medical that's actually beginning to do that for within the US. So you can actually go for surgery, get approval from your insurance company to actually get your surgery in a much more cheaper state, because there are some states that have a less lower cost structure, so the care costs actually that much more less. But those are the kind of things that you're going to basically begin to see that will pioneer more cost-effective healthcare to be provided. And it is incumbent upon us to actually begin to think in that way, or to explore those kind of opportunities, right? Otherwise, it's impossible. Obama or no Obama, let's put it this way, whether it's the Democrats or the Republicans, healthcare has no answer for any one of those guys, right? And they cannot afford to cut it.
Liz.
So, you mentioned diabetes, right?
Yep.
And as a diabetic guy, when sugar level goes 108, I get scared. I have a lot of friends, they say we never go below 100. And this is it's either they don't know what's going on, they are 133, 148, and this is causing problems later,
Yep.
right? And I think you said it's all done at home,
Yes.
right? And the consequences are
Yep.
a lot significant
Yep.
later on in life. So, most doctors, or they discover diabetes, they say lose weight. So
Yep.
generally, and that was the case for me, but I started building muscle mass instead of losing weight. And I think I see no sort of dietitian, because my wife is a dietitian, nobody really holding hands for these people, because they eat something and how it affects them, there is no knowledge, and it's as you said, it's a huge problem. How do you see this problem to be resolved or attacked?
Well, you're lucky you have a wife that's actually a dietitian. I wish I had one. I've been struggling with my pot belly for some time. Need to come to you to find out how to develop the muscle mass. But really, it's all about more cost-effective, coordinated care, right? Again, it gets back to the questioning that I was actually questioning the good doctor over here. When a physician is very busy. I mean, he diagnoses your chronic condition called diabetes. Yes, and he advises you what to do. But believe it or not, you as a patient have to be thinking about your compliance for that particular disease. It's not a disease that you literally can forget about, right? So you have to constantly be thinking about it. What can be done by the health? He as a physician would love to do more for you, right?
But that
Believe it.
service is not paid for.
It doesn't matter whether, but he would still, believe me, I can talk to as many physician friends of mine and they will tell me, you know what, if I have 1,000 diabetics in my panel, I would literally love to figure out how I can get more information out to them, guide them more, get them in more. Remember, if he knows that you're going down the wrong track, and if he can influence you to actually come in and pay him a visit, he actually makes money. Don't think that there's no money in this whole system by literally making patients. The main thing is to keep you out of the hospital, because the moment that you end up in that ER or the hospital, you're going to cost the healthcare system $15,000. Boom, right? So the idea is to basically keep you out of the hospital, but how can we now begin to influence you through coordinated care systems in your home? Begin to channel we can monitor their devices. I mean, I told you Kishore is actually at Aberdeen experimenting with wireless blood glucose monitors that will stream that information, right? Over to your physician, over to your dietitian, so long as you have provided brokering of that information to those people, right? Now, coordinated care can be provided based upon those signals. If your glucose is bad, he doesn't have to intervene. You could get an automated message on your cell phone that basically says, hey, Nilesh, take it easy, guy. Your glucose headed down the wrong path. Don't eat that gulab jamun that you're just about to swallow.
Okay.
There's a camera, right? It's monitoring you too.
Don't eat two, only eat one.
But that's what I'm talking about. I think that's where healthcare eventually is headed, is towards informing more as opposed to literally you at this point in time are just wanting to be dictated and being told what to do. And it's about taking ownership, like with anything else. Suresh?
I think technology is not the problem. We have access to a lot of technologies and they can be brought forward, but how do you monetize? So,
Who pays?
yeah, there are the insurance guys, then there are the doctors, but if you talk to a VC about this and you say, well, you talked about being informational, which is the Quantros journey, or attitude. If you say that to a VC, they're saying, are you crazy? We don't want to be there. So how do you navigate that?
I never had to go through a VC, so I don't know that. But the bottom line is, so first of all, what you ask for, monetization, is very, very important. The one advice that I can give entrepreneurs, especially if they have a technology platform that they've evolved that is really very broad, is to become very focused very quickly. Let me put it this way. There are a lot of companies out there that are providing remote patient care monitoring programs as of today. I know a number of companies that have actually even gone public that actually provide that. But they only focus maybe in cardiology. There's a company called CardioNet, for example, that literally does remote patient care monitoring for patients with cardiac conditions, arrhythmias and different kind of conditions and diseases, right? The more focused you are, the more chances you are that you will actually get funded and get monetized for that, right? Honeywell has a big, huge program that it puts in place to actually enable provision of technologies to provide for remote patient care, and they monetize it through saving, by providing proper metrics, through savings of money back to the healthcare systems, that they're either keeping patients, because remember, hospitals today, if that patient comes back as a readmission within 30 days, they're not paid for that patient. It's actually in the interest of the hospital if they end up discharging somebody for that person not to come back, right? He can come back 6 months later, he can stay 20 years longer and actually keep coming back to the hospital. He's a recurring revenue patient at that point in time. But the bottom line over here is to literally provide for the focused approach to your solution. It's never about, oh, my solution can do this, can do this, can do that. The solution can do everything. Get it very narrow, get it into the area, justified. So, for example, I would say just focus on diabetes and diabetes care, right? There's enough in that, as opposed to basically saying it provides for any kind of patient care monitoring program.
This is a question right here in the back, coming from someone who's in the home healthcare industry.
Good?
And right now, the industry and CMS, which I believe you work for some time.
Cutting back.
Right, just doesn't reward innovation. And I'm curious what your take on changes in that could be in the future.
Home care is at an interesting juncture, by the way. I think home care is going to begin to get redefined in terms of the kind of services that it will need to offer with the kind of technologies that can be provided for that particular environment. But the Honeywell model, by the way, that I spoke about is actually a very good model for you even to look at, because there are home care agencies that get certified by Honeywell to actually utilize those technologies And when they go in, they're providing a much more efficient model. So they're actually cutting back on their own cost. So their nurses don't actually have to go and visit the patient that many more number of times at home. So they're providing more, so you're receiving less number of dollars today, right?
Sure.
How do you still provide optimum care services for your patient population, but still make a few bucks to survive? That's the problem. And you can only do that if you actually efficiently utilize technology that can be made available, that is available today, right? So that's the way to think. But again, home care, I think, is going to, in my opinion, the future has a lot to hold for home care, because home care can begin to provide for that service component that can bring some of all of these technologies into the homes of people and enable them. So partnering with physicians, partnering with hospitals to convey the message that you're actually tracking and monitoring patients, and that way to decrease readmissions, on outcomes is better.
Questions?
So you already mentioned a little bit about international opportunities. So could you elaborate a little bit about what you thought about those in contrast, and whether you think like markets like the US, Canada, UK, and India will converge at some point?
Actually, we began to expand. About 2 years ago, the board actually gave us approval to go ahead and begin to explore the international market, and we selected 2 markets, the UAE and India. And we made a number of trips out, and we actually had signed contracts from Max Healthcare in Delhi and a couple of hospitals in the UAE. All of these hospitals are prime targets and ready. In India, for example, there are 1 million beds, 1 million beds additional, basically going to be provided for. The beds are not even enough. The clientele in India is actually beginning to become more discriminatory regarding where they go and basically seek care. And over there, it's basically pay for services, right? I mean, they come with boku loads of money and they drop it on the table and they pay for whatever that they basically need. Insurance services are beginning to evolve because as corporations like Cisco, Intel, Oracle are going, they're providing insurance services to their employees, right? So as that market begins to evolve, they will actually leapfrog into adopting a number of things that actually happen over here. Home care is not yet a predominant mode of provision of care in India. But believe it or not, I think it's very fast in the making and coming, right? That's how you have to think. What can we take from here that is actually working very well and adapt it into the market over there very, very quickly to establish a stronghold? So those markets are very much ripe today for the solutions that we have over here. They don't have the billing systems. Nobody's actually coding and billing, so the data and collection of all of that data that actually helps is not there. But it will evolve as insurance companies come about. Some hospitals are actually collecting Apollo. It's collecting ICD-10, not ICD-9 data.
You mentioned briefly about patients paying for healthcare, and a lot of consumer healthcare startups in the Bay Area over here. So curious to hear your thoughts a little bit more about, hey, wouldn't you pay $5 to monitor your health monthly basis? Where do you see that going? I mean, a lot of people think no. I mean, patients will never pay even $5 a month. And then on the flip side is employers, right? I mean, as you said, employers are paying for healthcare, so we are seeing a lot more of employer-sponsored consumer health kind of.
Sure. But I'll actually tell you to look a little bit more deeper, and you'll actually find more answers. There's a gentleman I know over there called Roshan. He actually works for a company called Executive Health Exams. Executive Health Exams. And what do they do, Roshan? Just briefly.
We do physical exams basically.
Huh?
We do physical exams.
Right. Private pay.
We do physical exams for
all Fortune 500 company executives.
So the rich that are not yet being taxed that much? No, the bottom line is there are people that are actually paying for certain services in order to be cared for. There are companies like VIP Medical that are actually evolving, that are providing concierge medicine. I mean, if the good doctors over here do not want to literally take insurance pay, but want to take private pay, believe me, they will have a panel of patients ready to take their services. The only thing is they will have to begin to make house calls, right? But those private pay patients pay that much more, and they would love to be cared for in, in the way that they can provide the services.
Do you see the mass market following along at some point?
It will. That's the only survival mode for the healthcare system, at least over here. It's not sustainable in the way that it is, right? It's not going to be completely self-pay, mind you, but it's going to be discriminatory self-pay for certain type of elite services that you might actually want to request for or need. In fact, you'll be penalized. So the good gentleman over there that was asking me about dietary control and things like that, the future is coming when, just like with cigarette smoking and the like, you're going to be penalized for certain bad behavior. If you are not going to control your blood sugar, you're going to be penalized for that. You're going to be charged a much higher premium than the other patient that actually can control their blood sugar. I mean, it's coming. It's not that way out there. The only thing needed is to bring all of this data together and make sure that the data is working to begin to get people to understand all of the analytics behind it. There was a news release, WellPoint. WellPoint is basically a large healthcare insurer and managed care organization. They're using the guy from Watson, the guy that actually gave the talk at time. They're using Watson to basically begin to drive therapeutic guidance for their patient population. So we're going to be playing Jeopardy with ourselves.
Anyone else? Okay, one.
First of all, great story, thank you.
You're welcome.
So just a quick question on the safety and risk component that you had in your product suite. So as a complement to that, do you also have a system that provides a number of errors that were prevented over time using the data that is reflected from the system, so the rest of the community continually reduces the rate of errors that are committed by profession?
So, just a quick follow-up question regarding those errors. Those are sort of logged in by you, by the company, or is it with the CMS? Those errors, the database?
No, some of the, all of this, the way that it worked was, it became a must-have for hospitals. The quality data, for example, needed to be collected. Of course, they were using our systems to collect all of that data. They could review that data, but that data needs to be submitted every quarter to CMS and the Joint Commission in order for them to get paid. Okay, it's all pay for performance as of right now in healthcare. The healthcare safety data, there are components of that data like hospital-acquired infections, patient falls, use of restraints, and a number of other kind of events that are basically not good to basically have on your patient population. That kind of data basically gets submitted to CMS as well. Okay?
So what is proprietary for Quantros in this case when you collect such data? If it's not dumped on CMS database or somewhere else?
Well, it's given to CMS so that they can basically figure out what to do with that particular hospital in terms of paying them, right? Eventually that data, a year later, 9 months later, you can go to a website called qualitynet.org or quality.org. There's so many, Hospital Compare is actually a website that they eventually publish the data. So you can go look up El Camino Hospital, for example, and you will find some of that data in those sites. That data is being collected through systems like Quantros and being sent over, but that data is not going to appear there tomorrow. I mean, it's going to come in 2012 sometime.
So is it possible, for example, if I want to compare Stanford, Mayo Clinic, El Camino, Cleveland Clinic, for example, how many infection-related deaths happened at Stanford due to, say, cardiosurgery in 2009 versus Cleveland, Mayo?
Sure.
Is it possible?
Yes, it is. I mean, you can go to Hospital Compare and do that today.
Do you have one more question? Just please focus on the question only, so you can get more people to ask.
So one of the things, since you mentioned executive health
I'll
checks,
answer that. Sorry, go ahead.
one of the things I saw in India, I was in India for the last 7 years, is what's becoming very popular there is what's called a master health check. For 2,000 rupees to 5,000 rupees, you get a varying amount of health check, which can include stress test, cardiology test, ultrasounds, etc.
Sure.
And they market that very actively now and use that as a basis for follow-on. I don't see anything like that really. Other than that, I've not seen it as popularly being used in the US on a regular basis, saying every year you go for a master health check of that nature where you get a complete test at a much lower cost than would normally cost for the individual tests.
Yes and no. I mean, I've seen variants of it. By the way, there's a company out in San Francisco that actually has, I don't know, MRIs or CAT scan. I mean, they basically put you and run a whole battery of tests and things for basically, I don't know how much the dollar amount is, 5,000, 10,000 bucks, but they actually do that. It's not prevalent over here because literally the focus is not there. Meaning that, look, the way that you, even yourself, because, and you can possibly afford that, are not doing that is because you're relying upon the healthcare insurance company to actually pay for it. In India, the mentality is totally different. People are used to basically paying for something like that, right? So they go right ahead and basically say, yeah, I would love to know, and they go ahead and pay for that. They're not waiting for somebody else to basically decide whether it needs to be paid for or not to be paid for. There's a big, population mentality shift that needs to literally occur before those kind of things become that much more adaptable.
Well, coronary